The small intestine takes up a large portion of the abdominal cavity. It is located mainly on the right side, along the right and ventral abdominal wall. The jejunum is the longest segment of the small intestine, floating fairly free in the peritoneal cavity. The ileum is the shortest and deepest segment that connects to the colon. The colon is divided into three segments: the descending part, located along the left side of the abdomen, the transverse colon, which extends crosswise just caudal to the stomach, and the ascending portion on the right. The cecum is located at the ileocoelic junction. In dogs, this segment is fairly large, sigmoid, and normally filled with gas, partly encircling the ileocecal valve, but in cats, it is small and typically free of gas. The duodenum is the first segment of the small intestine. It is divided into the cranial portion that connects to the pylorus, the descending duodenum along the right abdominal wall, and the ascending portion that becomes the jejunum in the mid-abdomen, caudal to the stomach. The stomach is also divided in several segments. The pyloric antrum connects to the duodenum via the pyloric canal, the gastric body extends ventrally, the fundus is to the left, and the cardia is located adjacent to the termination of the esophagus. Being able to comprehend these anatomical relationships makes ultrasound assessment of the GI tract a much easier task. Radiography remains an important tool in the overall assessment of the GI tract. The gas in this tube is an excellent natural contrast medium that, when present, allows us to identify its position and the shape and size of its lumen. Using radiographs, the position, diameter, and contents of the GI tract can then be evaluated, and certain foreign bodies can be detected, especially when more radiopaque than liquid or when delineated by gas. A barium series can also be done, but there are certain limits to this procedure. For quite a long time, ultrasound had limited usefulness in the assessment of the GI tract due to its limited spatial resolution, not to mention the presence of problematic artifacts. Despite certain limiting factors that remain, we can do some things with ultrasound that radiographs don't allow, such as directly evaluate the GI walls and adjacent organs. Ultrasound is now considered to be a more useful test overall, but yet remains most useful when combined with radiography. While technological progress has eliminated certain barriers, the main obstacle in GI ultrasound imaging is the GI gas and digesta, which tend to create several artifacts that can not only limit the assessment of the GI itself, but of the underlying structures also. But if we carefully plan the positioning of the probe to take advantage of the best acoustic windows, we can access and examine most of the regions of interest. The wall layers are generally quite distinct throughout all segments. The alteration of a single or multiple layers is typically linked to some pathology. Of all the ultrasound criteria, wall thickness and integrity of the layers are most significant when discriminating types of pathologies. The ultrasound anatomy of the GI tract is relatively simple. First, the serosa, the external layer, appears as a thin hyperechoic line. Next, the muscularis is anechoic, and the submucosa is hyperechoic, and the mucosa is anechoic. The internal surface of the mucosa is often covered by mucus and small air bubbles, and is hyperechoic. The lumen is usually either empty, or it may contain a small amount of gas or liquid of variable echogenicity. The appearance of the intestinal wall varies according to the plane of examination. Segments crossing the imaging plane perpendicularly will be ring-shaped with concentric layers, whereas the segments parallel to the plane of examination will show linear or curved layers. In this animation, observe how the appearance of the different wall layers from the lumen to the periphery varies according to the plane of the section and how dilated the lumen is. To measure the walls, the first cursor is placed on the external surface of the serosa and the second on the inner surface of the mucosa. Wall thickness will vary as you move through the different GI segments. In dogs, the duodenum is the thickest, whereas the colon is the thinnest. The different thicknesses will generally be proportional to the size of the dog. The relative thickness of the GI segments is different in cats. The thickest intestinal wall is the ileum in felines. However, as in dogs, the variable thickness of the stomach is influenced by dilation. This factor will have to be considered during measurements. Normal intestinal values have been established in empty GI tracts. A convex probe with a small surface area is the best to use when assessing the stomach. In the patient's sagittal plane, with the pointer placed cranially, the fundus is first evaluated in a transverse plane in regard to the long axis of the stomach. Because this dog is lying on its back, the fundus is slightly filled with anechoic fluid. The gastric folds are visible in the lumen of the stomach. It is sometimes useful to take a slightly oblique angle to get the best view of the entire fundus, and then slide the probe to the right to evaluate the body of the stomach before the pyloricantrum. Note the distinct wall layers and the prominent muscularis in this region of the stomach. The pyloric region is then examined in transverse plane up to the level of the gastroduodenal junction. The probe is then turned 90 degrees to evaluate the stomach in a longitudinal plane with the pointer towards you if you are on the right side of the patient. Examine the stomach again until you reach the gastroduodenal junction. In this video clip, observe the graininess of the images with the older ultrasound unit in the same dog but at a different time. The graininess is noise, and it's one of the factors that have been corrected in the newer models. Note that the stomach was completely empty during this previous examination. In some conditions, and especially in smaller patients, a linear probe may be the best one to use to obtain images with the best definition. In this clip, we have a very good view of the gastric folds and the different layers of the stomach wall. The duodenum is first examined at the gastroduodenal junction. The visibility of the junction is affected by the presence of gas and digesta in the pyloricantrum as well as gas and fecal material in the transverse colon located just caudally. Placing the probe under the costal arch or between the last two ribs and pressing slightly when needed, the duodenum is followed in transverse plane along the cranial flexure, turning the probe slightly as you move along. The entire length of the descending segment must be examined. Note the prominence of the duodenal mucosa in dogs. This segment has the thickest wall of the GI tract in this species. This transverse view enables us to locate the right lobe of the pancreas along the duodenum. The pancreatico-duodenal vein flows through the right pancreatic lobe and is a useful anatomical landmark. Observe how the duodenal mucosa appears grainy on these images due to excess noise. The noise will disappear in the next video, in which a linear probe was used along with special image filters. Several organs are visible at each side of the duodenum during this scan. The probe is then rotated 90 degrees, with the pointer now facing cranially to get a longitudinal view of the duodenum. The layers can be examined again in this view. Note the depression in the ventral duodenal mucosa. This is one of the Peyer's patches, which are often prominent in young dogs. A linear probe can also be used if a more thorough examination of the duodenal wall is needed. However, it may be more difficult to follow the duodenum, especially under the costal arch, to reach the stomach, due to the size of the probe. The right kidney and a few segments of the jejunum are close by. The wall of the jejunum, especially the mucosa, is much thinner than for the duodenum. The jejunum is the longest segment of the small intestine. Its loops are distributed in a rather random fashion in the abdominal cavity. The jejunum can be differentiated from the descending duodenum because of the position and thickness of the duodenum. The jejunum normally has a relatively uniform thickness along its entire length. The jejunum cannot be followed from one end to the other. Rather, the abdomen is scanned from one side to the other in different segments, while the intestinal loops are evaluated and measured occasionally. The jejunal wall thickness, as with the other intestinal segments, is generally proportional to the size of the dog. This partly explains the range of normal values that have been reported. A high-frequency linear probe between 10 to 15 MHz provides better image definition, which facilitates the examination of the different wall layers. Note the relatively constant thickness of the jejunal segments one after the other in these images, in transverse, oblique, and longitudinal planes, compared to the descending duodenum whose wall is obviously thicker. The ileum is a short segment with a wall that's slightly folded into the lumen. It can be more easily identified after the ascending colon is found in the right cranial abdomen, and is often located just to the right of the midline. In cats, this segment shows a typical wagon wheel or bullseye pattern in the transverse view. The colon can be assessed using a convex or linear probe with a higher frequency, as in this example, allowing an optimal view of the colonic wall. Even though the ventral wall is generally accessible, the presence of fecal material and gas cause shadowing and reverberation artifacts. This reduces our access to the tissues located deeper than this luminal interface. Note the thin wall of the colon, although the layers are distinctly visible. The colon is initially scanned in transverse plane from the descending segment along the left abdominal wall to the transverse segment, then to the ascending portion up to the cecum. Evaluation in the longitudinal plane will complete this examination.